So now we'll go into giant cell arteritis. Again, I have no relevant or any really financial disclosures. I like this quote: "To make no mistakes is not in the power of man, but from their errors and mistakes, the wise and good learn wisdom for the future." That's a quote from Plutarch. And my kids in one of their classes were reading a book by him called Lives, where he looks back at lives of kind of famous ancient people and did they do noble things or ignoble? So I thought that was a good quote. Okay, objectives. So we're going to understand the presentation of giant cell arteritis. We'll look at the diagnostic evaluation. When do you get a sed-rate CRP? When do you biopsy? When do you treat with steroids? And we'll try to formulate an approach, or at least inform your approach. I think one annoying thing about giant cell arteritis is there are frequent gray areas, and so there is room for judgment, but we'll try to look at some of the things that inform our approach to giant cell arteritis. And then we'll briefly describe the treatment. I think the hard part about giant cell arteritis is the diagnosis, right? I mean, that's where you get the gray areas. Once you know it's GCA, it's not so hard to say, well, we're going to do such and such. Okay, I wanted to start with a case presentation. So 63-year-old African-American man lost vision in one eye, didn't come to the hospital. A couple days later, he lost vision in the other eye. He had hypertension, diabetes, he was a smoker, and I'll try to move along here in the interest of time. So he had bilateral central retinal artery occlusions. All right, so next steps. Do you say, well, he's African American, that's GCA doesn't really happen that much there? Hopefully not. So you say, well, let's do the workup we're supposed to do, right? The SED rate was 59, the CRP was 95. He was started on IV steroids. He had an embolic workup that was negative. He had bilateral temporary biopsies, and one was positive, one was negative. And really, once you get a positive biopsy, it's so unlikely to be something else mimicking, and that confirms the diagnosis of giant cell arteritis. So he was started on long-term prednisone treatment and tocilizumab, which we'll talk about. You can refer to a rheumatologist, and they can prescribe that. So giant cell arteritis, when to order ESR, CRP, and CBC? Mostly you should order those if you have a reasonable suspicion. I say reasonable. 52-year-old patient comes into your office and says, hey doc, I've got a little bit of a headache, and otherwise nothing. Well, no, you're not going to order it then, right? So you don't order them all the time, but once your suspicion is up enough, you're going to say, yeah, it's probably worth getting these lab values. When to biopsy, when to do a bilateral biopsy. And then a lot of folks are doing ultrasounds now, so cranial ultrasounds, and they'll also ultrasound in the axilla to look for signs of giant cell arteritis via ultrasound. So a foundational study when we're thinking about what's predictive of someone having giant cell arteritis is this study by Hayray in the 1990s. They had 363 patients, and 106 had positive biopsies, so about a 30% a positive rate. And they looked at, well, what were the lab values or what were the symptoms that were predictive of a positive temporal artery biopsy. So jaw claudication was the highest. That gave an odds ratio of 9 times. So that's the largest and sort of way above the other ones. Neck pain, which was predominantly in the back of the neck, in the occipital area, was 3.4 times greater. A C-reactive protein greater than 24.5 milligrams per liter was 3.2 times greater. SED rate, 47 up to 107, was 2 times greater. If it was higher than 107, they had an even slightly higher ratio. And age greater than 75 was 2 times greater. So the older the patient is, you should be more concerned for the possibility of giant cell arteritis. So I wanted to give a cautionary point. Although Dr. Hayray uses a CRP value of 24.5 milligrams per liter as having an odds ratio of 3.2, the normal value of a C-reactive protein in his study was 0 to 5 milligrams per liter. And what's interesting, in his study, he talks about the C-reactive protein as having 100% sensitivity for giant cell arteritis. So that is, no one who had a normal CRP had giant cell arteritis. But what's interesting, when he makes that statement, he's using the value of CRP of 5 milligrams per liter, not this CRP value of 24.5. He just found the 24.5 was more useful for being predictive, because if you just had anything that was positive, it lost its predictive value because a CRP of 7 wasn't especially helpful. So just be careful of that. Oh, actually, and while I'm on that topic, I don't know if any of you like reading about giant cell arteritis, but there was a recent study out by Johns Hopkins where they said a C-reactive protein was only 82% sensitive for giant cell arteritis. Did anybody read that article? It's okay if you didn't, but okay. Well, if you do read it, you might be like, wow, that's a lot different than Hay-Ray, which was 100% sensitive. Well, what was the threshold that the folks at Johns Hopkins used? They used Hay-Ray's 24.5 milligrams per liter, and then that was their definition of normal. Well, so there were 18% of people that had a CRP that was lower than 24.5 milligrams per liter. So I think it's still true that if you have a normal CRP, the normal by the actual lab cutoff of 5 milligrams per liter, then giant cell arteritis is unlikely. Now, I'm still not going to say 0 because we'll get to that in a moment, but it's unlikely. So there are case reports, unfortunately, of patients who have both a normal ESR and CRP who could have giant cell arteritis. So that didn't happen in Hay-Ray's study of 360 people, but there have been case reports. So this is a table from Dr. Hay-Ray's study, and basically it says what I was just saying. The open circles are positive temporal artery biopsies, and the dots are negative. And there were no open circles within this in this box on your lower left where it's all normal. So that's why a normal ESR and CRP, extremely reassuring, not 100% reassuring, but extremely reassuring. Okay, so now here's a case from JAMA Ophthalmology from September 2017. I really like how they have the little case reports with a photograph of the patient if you've looked at those. There was a 66-year-old woman with a spot in her vision for 2 months. She reported some right-sided jaw pain that kind of went to her temples, ear, neck pain, left shoulder. The pain did seem worse with chewing, but a mouth guard from her dentist significantly helped this pain. So you're in there trying to discern. You say, oh, the mouth guard helped. Good, not jaw claudication. Should we make that conclusion? She had lost some weight over a few months. She was a smoker, so she had cardiovascular risk factors. She's 20/25 in each eye. And then on the photograph, she has this large cotton wool spot, which that was the spot in her vision. Her SED rate was 2. You can't get much lower than that. Her CRP was 4.9 milligrams per liter. So what should we do? Do we say, SED rate CRP normal? Our data says super unlikely to have giant cell arteritis. Or do we say, well, her history sure sounded like jaw claudication, and yeah, it was helped by the mouth guard, but there is something called the placebo effect, so maybe that had a role. So anyway, thankfully the investigators of this case, they went ahead and they got a temporal artery biopsy, and it was positive for giant cell arteritis. So just know you can have normal inflammatory markers. And I like that case because don't be too quick to dismiss someone's jaw claudication. So we teach our residents, not all jaw pain is jaw claudication, right? Because you often ask people, are you having trouble chewing? And they'll say, oh yeah, doc, my tooth, And they'll tell you something that you're like, okay, that's clearly not jaw claudication. But if there's a mixed picture of jaw claudication, don't automatically dismiss it as the patient just saying yes. Because I don't know do you have the patients who say yes to everything? Like I have some of those. And I feel like that can kind of make you then not on your guard so much for a patient like this, who you find a reason not to think it was jaw claudication when really it was. So you have to kind of filter through that. Don't be too quick to call it jaw claudication, but don't be too quick to say someone's symptoms are not jaw claudication either. Okay, so then some investigators from Duke, they published a study in 2015, which is very similar to Hay-Ray's study from the 1990s, where they looked at lab values and symptoms. And then I'll show you their table in a moment, where they came up with a diagnostic algorithm as a way to sort of help us think through giant cell arteritis. They found that platelets greater than 400,000 gave a relative risk of 3.3, jaw claudication relative risk of 3.3, and an elevated CRP relative risk of 1.8. So similar to Hayray's findings, notice here that they didn't have neck pain as one of them. And here is their diagnostic algorithm. And unfortunately, it is too small for me to read from here. If you're interested, you can look up the study. But basically, they have 7 points. Some are the ones that you would think that they should be, like some kind of ischemic vision loss. So ischemic optic neuropathy, central retinal artery occlusion, or transient vision loss. So don't forget transient vision loss. In a GCA patient, that can be a sign of impending loss of vision. So sometimes residents will tell me, it's reassuring that they're 20/20. Well, yes, it's reassuring right now they haven't lost vision yet. But in GCA, your job is to prevent vision loss. So if they have amaurosis fugax, transient vision loss, that is impending vision loss. That should be treated with the same urgency as if they'd already gone blind in one eye, because you want to stop them from going blind in an eye before it happens. Okay, so other things, elevated ESR and CRP, new onset headache or neck pain, jaw claudication. The thing about jaw claudication, that's so specific for GCA, especially in an elderly patient. I feel as though that alone should be, hey, let's get a biopsy. If you feel the temporal artery feels nodular or pulseless, polymyalgia rheumatica, constitutional symptoms. So they give a point for each of those. If you only have one of those points, they say no need to biopsy. 2 or more, they recommend a unilateral biopsy. I'm sorry, 2 is unilateral biopsy. More than 2 then becomes bilateral biopsy. Now, the thing about an algorithm is, to me, although they have to kind of make all the points equal to sort of make the algorithm simple, obviously they aren't all equal. As eye doctors, once they have a number 1, some kind of ischemia, then yes, any of the others, go ahead and proceed with a biopsy. If you happen to come across somebody, though, who says, oh, I have a headache and I've lost some weight, well, you're probably not going to send that patient for a biopsy, right? So that's the thing with an algorithm. You have to sort of use it in its appropriate context. But I think it is helpful. So I think it is good just to look. And again, the thing is, you can sometimes feel like you're doing too many biopsies. I don't know if any of you have had that experience. But you're supposed to do more biopsies than you actually find giant cell arteritis, because unfortunately with GCA, the goal is not to miss it, not to sort of have the best percentage of like, I didn't order any unnecessary ones and only ordered necessary ones. And yeah, I missed a couple cases of GCA along the way, but overall I was pretty accurate. Like, that's not the goal. The goal is not to miss GCA. Okay, so there was another study out of Johns Hopkins recently. It was looking at race and giant cell arteritis, and many older studies concluded that GCA was primarily a disease of white populations, maybe because they were done, I don't know, in Minnesota or somewhere where you had just large Scandinavian populations. But in the Johns Hopkins study, it was equal among whites and blacks. So don't let race be something that would stop you from pursuing giant cell arteritis. As you saw, this case that we started off this talk with was an African-American man who had GCA. I wanted to briefly mention the American College of Rheumatology criteria. So the rheumatologists, they have a different perspective on giant cell arteritis than ophthalmologists. They think a temporal artery biopsy is only 50% sensitive, so they don't give as much weight to that as ophthalmologists do. Dr. Hayray's study, as well as the Duke study I mentioned, found a sensitivity of closer to 90%, maybe 88%, somewhere in there. The thing with the rheumatology criteria is they have a lot of criteria, and they had a validated set of people that they said had GCA, but they weren't confirmed with a biopsy. So I think that the controversy between neuro-ophthalmologists and rheumatologists is, well, did the people who really have GCA that the rheumatologist said they did, was it really that the biopsy missed the cases, or did a significant percent of those people not have giant cell arteritis? Okay, so. Do you recommend a bilateral initially? So the question was, do I recommend a bilateral biopsy initially? So I think it depends if you are able to get a follow-up biopsy within time, then I like to just do a unilateral biopsy initially. Again, you're going to catch 90%. According to the ophthalmic literature. And if you can then get a second one when needed, if your suspicion is high enough. I think that's reasonable. A biopsy, the risk of a biopsy compared to losing vision from giant cell arteritis, compared to that, they're minimal, but they're not zero. And so things can happen, especially it depends. If you're doing the biopsy yourself and you kind of do it back just above the ear, I think that the chance of getting the facial nerve and getting brow ptosis is pretty small, but there's still some other risks, scalp necrosis, infection. So if you're able to get the second one when you need it, I would recommend just doing a unilateral initially. There are neuro-ophthalmologists though, because that whole issue of can you get the second one within 2 weeks is so hard, they do just send people for bilateral. They just say, hey, that's not practical for us. Giant cell arteritis is terrible if you miss it. We send for bilateral biopsies. Or if you wanted to have like where your suspicion is high enough for a patient that you already know if the first one comes back negative, that you want the second one, and it's hard to get that second one in time, then go ahead and send bilateral initially. But if you can get the second one in time, I think it's reasonable to just do a unilateral. And you save tissue. The other thing too is, what if this patient has a flare-up of symptoms 3 years later, and they've already had both temporal arteries removed? I mean, yes, you can try to find some other place to biopsy, but are people used to doing that? And so it is nice to always have sort of, hey, we can go to that other side at some other point if we need it. So that could be an argument for not doing both right away at once too. Okay, so again, this is kind of too small for me to read, or actually over here I can read it, but so again, 6 points or more gave people a diagnosis of GCA. Again, overall, this rheumatology criteria, it's very similar to what we have in ophthalmology. Just a difference might be that you could get to 6 points, get a diagnosis of GCA, when maybe as ophthalmologists we'd say, we still think that risk might be low. So although we have this difference with rheumatologists, I will say rheumatologists are your best friend with GCA, and I respect them immensely. And we need their help. They help us manage the long-term side effects of prednisone. They will prescribe this new medicine called tocilizumab, which is an interleukin-6 inhibitor, and it can treat GCA without all the bad side effects of prednisone. So I recommend if you have anyone who's positive for GCA, refer them to rheumatology if you have that available for their opinion, and they can help and they can decide if the patient can be on tocilizumab, and if they can be, then the prednisone is often tapered more quickly, which we may talk about a little bit of that treatment here. So there isn't a randomized controlled trial to prove this, but if somebody has had vision loss from GCA or impending vision loss, so again, impending vision loss is they're having transient vision loss, then the experts recommend now doing IV steroids. So again, not proven, but the idea is you're trying to do as much as you can to shut down that inflammatory process. If there are no visual symptoms, or I like to think, you have those patients where you feel like, I feel like I should get a biopsy here, but I doubt they have GCA. Those patients I'll start with oral prednisone. And of course, you don't wait for the biopsy result to start the prednisone. Go ahead and treat, because someone could lose vision at any moment from giant cell arteritis. Once they're on treatment, you do a slow taper, 6 to 12 months or longer. And again, if you refer to rheumatology, they'll help you with the management of the prednisone side effects, and they may prescribe this medicine called tocilizumab. All right, so here are some key points. So usually a normal ESR and CRP makes GCA extremely unlikely, so that's very reassuring. But again, not 100%. So if you have some compelling clinical reason, either history or exam finding, you may still want to start steroids and do a biopsy. Algorithms are helpful, but clinical judgment is still required. I would recommend, though, when in a gray area, that's where the algorithm is helpful. And you'll normally find if you're in a gray area, the algorithm will probably push you to doing the prednisone and biopsy. Again, you just hate to miss it. Now again, is there judgment on that? Yes, if someone, again, 52 with a little bit of a headache, I don't think that's enough to sort of go down that road. Well, actually, and if that's all they had, the algorithm would say no too, but let's say they had some scalp tenderness or something as well. Also, when there's a gray area, you can include patients in the decision-making process. You have to be careful with this because they're obviously not informed about it. So it's almost, if you almost think they don't need a biopsy, but but there's enough there that's making you feel like, well, then you can talk to them about it, because some patients are like, hey, if there's a chance of anything, I want the biopsy, right? So that can help kind of push you one way or another. The other thing I didn't talk much about during the talk, but temporal artery ultrasound, I think is helpful. It's not the gold standard. We have rheumatologists at our hospital that have done this a lot, and they'll say to do the extracranial arteries in the head, and they also do it, the ultrasound in the axilla. And if they find a halo sign, it's reasonably specific for giant cell arteritis. Again, not 100%. But I think that can help, and that can be another thing to do in a gray area too, where if you think, gosh, does this patient really need a biopsy? Again, it should be pretty low risk if you're even having that sort of question. Then you could refer them to rheumatology, get their opinion on the risk of GCA, and they could do an ultrasound. Again, African Americans likely have the same rate of GCA as white people, so don't let race stop you from investigating GCA. And again, consult rheumatology for help in both diagnosis and management. All right, well, thank you all very much. Do you guys have any questions about GCA?
Your slide about treatment 4 times a day with 250. Hayray pounded us as residents that steroids are a big bolus once a day, and 4 times a day is all it does is decreases the effectiveness and increases the side effects.
Right. So yeah, so there are different recommendations about that. And Hayray actually, when people wrote that was the recommendation, he said that IV steroids versus oral, he kind of wrote it and said, hey, in my experience, IV didn't make any difference from oral. So now as for bolusing it,
Given 120 milligrams of oral.
yeah, right, he would just give a bunch of oral. But again, the expert consensus among most neuro-ophthalmologists is to do IV. And that's a good point. Should you do it all as a bolus? I think that you could. You're right, I haven't really looked into why that was recommended as 250. I think the point is give a good dose of IV steroids and you've maximized reducing GCA. And like, you're right, if you do 1,000 all at once, I guess now they've gotten that max dose instantly. I think one concern was in the elderly is giving a higher dose more risk, but that's interesting. Does it actually increase the risk to sort of spread it out? Maybe it does.
Occasionally, a rheumatologist will send someone that's been on low-dose steroids for about a month. Maybe they saw their PCP and were started on it, and they're asking for a biopsy. And what do you do in that situation? That's a common thing that happens in my clinic.
Well, so I think it's a judgment call, but if it's low dose, it depends how low the dose is. Yeah, I mean, because we don't think, if that's all they've been on, we don't think 10 really would control an initial flare of GCA anyway. I think it's reasonable to do the biopsy. There have also been reports of partially treated GCA for months that still had a positive biopsy, like active inflammation. And sometimes you can see signs of healed arteritis, so the biopsy may still help you if there are signs of healed arteritis. So I would say a month of low dose, yeah, it's probably still worth it, just because if you can confirm it on that biopsy, you have your answer. Now, if it's negative, yeah, then you're still sort of like left, maybe not as helpful. But I might do a unilateral biopsy in that case. I think it's reasonable. Again, judgment call. But
is there any known correlation between vitamin D levels and risk for GCA?
I'm not familiar with that data. It makes you wonder, because vitamin D obviously is involved in our immune system, and certainly there have been some connections with that in MS, although even with MS, I don't think it's proven. But that's a good question. I don't know enough about that.
From an ophthalmologist standpoint, when there's a low suspicion, is there ever a role for us to use a subtherapeutic dose, like just 20 milligrams while you're waiting for your labs to get back, and you get a biopsy scheduled? If you're not going to be doing the biopsy, you're going to refer it out to a general surgeon. It's a little delay, but there's a low suspicion. Rather than not doing anything before the biopsy, just using something low dose instead of the full thing.
Right. So yeah. So if you have a significant suspicion for GCA, you're not supposed to wait for the biopsy. You would just start full dose. If what you're asking is, well, should you even start steroids before you get the SED rate and CRP results back? Maybe. So, I mean, so you get into like, how reliable is the patient? Are they going to get the labs right away? So I think you could make an argument, hey, get the labs drawn today, and they tell you, well, doc, maybe I'll do it tomorrow, and so you say, okay, well, why don't you, after you get the labs drawn, let's put you on some prednisone to sort of kind of hedge your bets of whether they're going to be in touch, I think you could make an argument for that. I would say, though, the best thing, like what Ray did, was he had patients, I think they had a lab somewhere either in their building, and they had to get the blood drawn and sit in his office until they got the results. So that way you didn't unnecessarily treat with prednisone. I mean, something like that would be ideal, but you're right. What compromises do you make, though, in the real world, where what's the delay going to be between sed rate and treatment?
So I've now seen 2 patients that had a clinical presentation that was basically indistinguishable from giant cell arteritis about 4 to 6 weeks after having COVID. Okay. They had pallid disc edema, ipsilateral headache. Temporary biopsies were negative on both. Is that something that you've seen? In both of these cases, I treated them just like they had GCA, and they both did reasonably well in the contralateral eye.
Yep. I have not seen that. And how old were they?
60-ish.
So he said 60-ish. Yeah, I mean, and by pallid disc edema, you mean acutely pale, right? So you saw them within the first week or 2 and they had pale disc. Yeah, I would, in a 60-year-ish person with pallid disc edema, I would treat them as GCA as well. I mean, did the COVID trigger it? But again, we don't know what triggers GCA normally, right? There's some response. There's some infection or something else that triggers the immune system. So I think you're right. Just because you can blame it on COVID doesn't mean it won't behave like GCA otherwise. I think that's reasonable.
Right here.
I have a unique patient. She's a 77-year-old, my sister in Christ. She's all of 100 pounds wet. Her daughter's also my friend who doesn't like me to treat her. And this is a struggle between medicine and faith. She has biopsy-proven temporal arteritis in Ohio.
Okay.
She doesn't have any vision loss, but she is symptomatically just weak and can't function. So every time she goes through an episode, I stick her back on prednisone because I'm worried she's going to lose vision. And then her daughter gets frustrated with me because she believes, as I do, in divine healing. But I mean, there's got to be a better medicine for her, and so now I'm struggling with the rheumatologist who's trying to get something approved through her insurance.
Right.
And what is your second line, because she doesn't do well on steroids?
Right, so this new medication called tocilizumab.
That's the best.
Well, yeah, I mean, it's FDA approved, so I think encouraging a rheumatologist to do that would make sense. I think that's, I mean, you can try methotrexate or things I'm not, a little outside my expertise, but tocilizumab is a big one now to try. And I think that's my time, it's 8:30.
I'm going to take the privilege of asking the last question.
Okay.
Actually, a case presentation, last question. So do you have any use for fibrinogen levels? There's been some reports about that with GCA. And then I had a patient that came in this week, gave a pretty good history of amaurosis fugax, one eye, cardiovascular troubles, had cabbage in the past, sees a cardiologist, had an echocardiogram recently, not for that reason, just for other reasons. No other symptoms, no jaw claudication, no weight loss, no headache, nothing, except for some joint pain. I sent him to the cardiologist to get a carotid ultrasound, and I said, you know, maybe we ought to just go ahead and get some labs. So ultrasound was normal. Sed rate was over 100 and CRP was over 100. No other symptoms.
Yeah, well, and so 20% of people with GCA will not have the other systemic symptoms. So I know that's why sometimes it feels like, do I want to go down the road of ordering a sed rate and CRP? Because if these are high, am I then obligated? But the problem is GCA is just so devastating, and if 20% of people don't have symptoms, other symptoms, you hate to miss it. So thank you all very much. Appreciate it.